Yeah, last week was so nice. We had a very good medical student, and he did a pretty good job. We all agree. Yeah. So if there is no one,
Yeah, that was.
we can proceed, David. Right?
Yeah, I think let's proceed. Others will join us as we proceed.
Yeah. So today to be a bit longer case, so I'll take it fast, and the information will be compressed into some few aliquots so that we have enough time to discuss and for teaching, and we make sure that we don't finish beyond the hour. Uh, to start with the chief complaint, so this was a 29-year-old female with intractable nausea and vomiting that was admitted to the hospital I work.
Okay, so because you say the case we finish on time, so we can maybe take a few minutes to orient some newcomers because I've shared the link to a wide audience today. I'm not sure how many newcomers have joined, so I'll try and be very quick so we finish on time. So when I hear about nausea and vomiting, I think these are very common. They are very common complaints that we come across, and maybe so one way to think about is basically it's very difficult to make a diagnosis with nausea and vomiting itself until you hear about accompanying symptoms, because as much as nausea and vomiting, we think of them as symptoms coming out of the gastrointestinal system. So you could think of things like gastritis in particular, or gastroenteritis in general. So local causes, we tend to be more biased toward local causes, but you can have nausea and vomiting as a result of systemic illnesses, with nausea and vomiting just as part of the presentation. So I'll just give a few examples, and then I'll let Joseph present the HPI so we can make progress. So, for example, patients with a protozoa infection or a parasitic infection like malaria can present with nausea and vomiting. That's a systemic illness. But because of some pro-inflammatory cytokines that are released, this patient is presenting with nausea and vomiting. Someone can present with nausea and vomiting as a result of pathology that is limited to the CNS. So, for example, increased intracranial hypertension of any cause can present with nausea and vomiting. We have primary headache syndromes like migraine and others that can present with nausea and vomiting. And then nausea and vomiting can be a side effect of medications, can be as a result of some sorts of poisoning. So it's a very broad complaint, and it's until you get some symptoms that are helping you to localize in a particular organ system, that's when you can that's when you can start making some progress. Of course, in a 29 years old female, not to forget pregnancy. So the HCG, the human gonadotrophin, will be driving her crazy, leading to the nausea and vomiting. So it's very broad. Joseph, let's hear the HPI and see if we can make any progress.
Sure, that's a very good start. And so here's the HPI. Patient reports that 1 year ago, she presented to another facility with excessive urination and thirst. Her RBG was taken and was found to be 28, and she was diagnosed with diabetes mellitus at that point. So she was started on insulin based on that high RBG, and over subsequent days, her RBG went within normal limits. But after 4 months from that diagnosis, she started experiencing nausea and vomiting. She reports that she experienced multiple episodes of vomiting within a day, such that she couldn't eat anything the whole day. The vomiting occurs whether she tries to take a meal or even without taking a meal. The vomiting goes up to 3 weeks and then resolves, only to come back within the next 2 weeks or so. and the cycle would repeat itself again. The vomiters contained recent treated material if she had eaten, but it was just watery vomiters if she didn't eat anything. But sometimes she would vomit and nothing came out. It's like retching. The vomiting was associated with upper abdominal pain that radiated to the back, but due to inability to eat, so insulin caused hypoglycemia, and she was switched from metformin to glimepiride for diabetes. She posted that her weight dropped from 60s to 40s when I saw her, and she became so weak she couldn't walk without assistance. But she denied diarrhea, constipation, difficult swallowing, early satiety, autoalimentation, seizure, double vision, headache, or rash. She was being prescribed as needed metoclopramide and ondansetron, which didn't help at all. For the past couple of months, patient kept getting in and out of different hospital for these complaints, and my hospital was another one that she came there and she found me there. Review of the system, she reported numbness of the feet. She said that she didn't see her menses for more than 6 months. She didn't have shortness of breath and no cough. Past medical history, diabetes mellitus, but no previous surgeries. Meds, she was on metformin and glimepiride. She was on as needed on ondansetron and metoclopramide. Family and social history, she's single. She was working as a tax officer before, but she has to quit because of this illness. Her father died years ago. The cause was unknown. Her mother was still alive and healthy. She had four siblings who were also in good health. She doesn't drink or smoke anything.
Oh, Joseph, I'm not sure if it's my internet you're breaking.
Uh-huh. But you can see the slides. Hello? Can you hear me now? Hello?
Yeah, so the last paragraphs I think I could hear well. I was following the slides, but you've been breaking a number of times. I'm not sure if it's my
Mm.
internet or everyone else is getting the same problem.
Yeah, I think it's my internet.
Yeah, but I could follow the slides. So done with the history, right?
No. I have some. Can you see the slides?
Yes, I can see the slides.
Which slide are you seeing right now?
Family social history.
Yeah, so I think the internet reconnected. So let's see if there is any. Yeah, so this is the last slide of the history. Sorry, it's a long, but it has to be this because it will be a long case. Yeah, so let me take
Okay,
you
no
back to the
problem.
HPI, and you will discuss from here, right?
Yeah. Yeah, so I'll try to be fast also to keep time. So like I said, nausea, vomiting, very non-specific. You have to find some accompanying symptoms to figure out what is going on. So I'll try to track back and see if there is anything that can be value for me to make progress. So this patient initially presented with symptoms which are very suggestive of hyperglycemia. So increased the thirst, excessive urination, a diagnosis of diabetes is made, and she's immediately started on insulin, and the RBGs went back to normal. So what's I mean, just based on this history, of course, when we talk of something like so, for example, someone with hyperglycemia, the way we can explain nausea and vomiting is, for example, patients with diabetic ketoacidosis can present. So we know the presentation of diabetic ketoacidosis. So these patients can also present with nausea and vomiting. But So of course, I think there would be more than this, because we are talking about a 2 years history of nausea and vomiting. I'm not thinking, I do not think that the patient would be working with diabetes of 2 years at least. If we talk of type 1 diabetes, of course, one thing that I'm looking for, this patient doesn't seem to be, although I do not know the height of the patient, but we are told that weight decreased from 60s to 40s. So for a 29 years old female, of course, I would need her height in order to say if she was overweight or obese to begin with. But otherwise, so I have some questions even with the diabetes, whether we are talking about type 1 diabetes or type 2 diabetes. Very hard to tell sometimes because of limitations in our settings. But so if we are talking of type 1 diabetes, for example, working with type 1 diabetes for 2 years, and the sole symptom being nausea and vomiting, of course, that would be very hard. And uh, most likely the patient would have suffered from diabetic ketoacidosis, and that would have led to a diagnosis of type 1 diabetes. With type 2 diabetes, of course, someone can work with it for a number of years, lead to end organ damage, and then the presentation is
Yeah, sorry,
so
David.
what the patient
Uh,
is presenting.
so,
Yes,
so to make sure that you're solving the right problem, the diabetes was 1 year ago. Nausea and vomiting is like
yeah.
8 months, because 4 months after diabetes and then nausea and vomiting.
Okay, so basically the nausea and vomiting came after.
Yes, like 4 months after the diagnosis. So it's like 8 months.
Okay. Okay, so 8 months after, I mean 4 months after diagnosis of diabetes. Okay, so the initial symptoms are symptoms which are suggestive of hyperglycemia. Patient is started on insulin, then 4 months later, nausea and vomiting. Now, let me see if there's, so this vomiting is seems to be very cyclic based on the last paragraph there, the last bullet, that the vomiting goes up to 3 weeks, resolves, comes back within the next 2 weeks or so, and the cycle repeats. So we see that the vomiting is cyclic. So some diagnoses are starting to come up, but then of course not everything is tallying. So just to make sure that I do not forget the bias that is coming up to me, we have what is called a cyclical vomiting syndrome, which is where a patient presents with cycles of nausea and vomiting, which of course can be very difficult to control with even with antiemetics, and then the nausea and vomiting will resolve uh, spontaneously and then come back after a while. Of course, I'm not very sure about the timing, whether these timings are in keeping with that, but of course, cyclical vomiting syndrome, I think, is one of the things that I need to entertain. Another one, can we go to the next slide? Yeah, so another diagnosis that I'm thinking about is um, again, of course, trying to establish what exactly you are dealing with. Is it type 1 or type 2 diabetes? But patients with diabetes can, of course, suffer from diabetic gastroparesis, which can lead to nausea and vomiting. But so these patients are having symptoms of abdominal fullness. They do not feel like they are hungry. They experience episodes of nausea and vomiting, of course, sometimes during the nights or early mornings. And based on the fact that this patient is also having symptoms of peripheral neuropathy, because we are told she's having numbness in the lower extremities, so that is another consideration. But we do not see signs of end organ damage, especially in the autonomic nervous system, at least so far, which would be in keeping with this. So whether this patient is also having episodes of constipation, diarrhea, which would be suggestive of autonomic neuropathy, which is also involving the GIT. So cyclical vomiting syndrome, diabetic gastroparesis, I think these are some of the things that I am considering at this point. So I'll just scan the slides quickly just to see if I'm not missing anything. So the weakness, I'm thinking, of course, it's a weakness, it's prostration because of the vomiting. Because of this vomiting, so the patient cannot keep down anything, and that's the reason why. So the patient is already losing a lot of weight. So uh, it's because of energy deficiency, basically, from the fact that she cannot keep anything down. Probably that's why she's so weak that she cannot walk without assistance. Can I see the next slide? Yeah, so another thing that I am missing, I mean that I should not miss from the previous slide. So this patient is having, is that epigastric pain? If you can go back to the last slide. The patient is having abdominal pain, upper abdominal pain that radiates to the back. So this upper abdominal pain that radiates to the back, so of course we can interpret this as epigastric pain. So peptic ulcer disease, Joseph, can you tell us the nature of this abdominal pain, whether it's burning, whether it's sharp pain or dull aching? What's the nature of this pain?
Yeah, so I would say it's dull pain.
Okay, so dull aching abdominal pain in the epigastric area.
Yeah.
Not very characteristic of peptic ulcer disease, which would be burning in nature. But then those possibilities: peptic ulcer disease, gastritis. But then another thing uh, that is important is the patient is experiencing epigastric pain, and yes, so I see Kalani is having the same thoughts. So epigastric pain radiating to the back. Another thing is pancreatitis, new onset diabetes, and then the patient is also experiencing this epigastric pain. So that is the main reason why I had to come back to this. Of course, pancreatitis can explain this abdominal pain, and of course it can explain the diabetes, the new onset diabetes. But then if we talk of chronic pancreatitis, which of course would be the case in this patient, because acute pancreatitis not likely for a year or more. So acute pancreatitis not very likely, unless we are talking that the patient is having recurrent episodes of acute pancreatitis, for which we would expect the patient to have waxing and waning of these abdominal pains. And of course, Joseph is telling us that this patient doesn't use alcohol, which is one of the commonest risk factors for pancreatitis. And we would expect other symptoms. So if the patient is experiencing endocrine abnormalities from the pancreas, that is the diabetes, and this abdominal pain, maybe there will be also some element of exocrine, uh, dysfunction of the pancreas, like this patient would be having steatorrhea, so we would expect many episodes of diarrhea also, which we do not see in this patient. But regardless, I think it's something that I also need to take on board. So cyclic vomiting syndrome, diabetic gastroparesis, pancreatitis, and then not to forget peptic ulcer disease / gastritis, which are not very likely in this patient. Can I see the next slide? Okay, so yeah, no diarrhea, constipation. I think I already discussed these ones. No altered mental status, no seizures, double vision, headache, or rash. And the patient is okay, is moving between different hospitals. Review of systems, I've discussed the peripheral neuropathy. So the patient is the patient has some sort of secondary amenorrhea more than 6 months, not explaining her menses. So when someone has massive weight loss, when someone experiences massive weight loss, that's something that can happen. So with uh, drastic changes in weight, whether weight gain or weight loss, someone can have amenorrhea from that. So that would be a possibility. but then am I missing something else? I mean, let's say something, an endocrine abnormality, which would explain amenorrhea, which would explain uh, new onset diabetes for 1 year, and then the nausea and vomiting and the peripheral neuropathy. Maybe not very likely, but so for something endocrine, the patient is becoming weak, losing weight. Adrenal insufficiency would explain the weakness, would explain nausea and vomiting, but then adrenal insufficiency, I cannot see a way to explain new onset diabetes, and yeah, especially new onset diabetes and the symptoms of peripheral neuropathy. So I think the review of systems, probably I'm attributing the numbness of the feet to diabetes. It could be due to something else, but I'll clarify my thoughts as I proceed. Next slide. Next slide, Joseph. Okay, so diabetes, no previous surgery. Next, yeah, metformin, glimepiride. So these ones, the patient started using metformin and glimepiride because of the hypoglycemia due to the nausea and vomiting, right? Right, Joseph?
Yes.
Hello, Joseph.
Yeah, David.
Yes.
Yeah, yes, that's true.
Yeah, so because I know that metformin can present with some GI disturbances, but more in the form of bloating, diarrhea, rather than the nausea and vomiting, which is also likely. But of course, the temporal relationship is this patient started with the nausea and vomiting, so that was the reason for instituting the metformin. So probably it doesn't explain these symptoms. Can I see the next slide? Okay, so uh, nothing significant in the family history, and this patient doesn't smoke or drink. I discussed about drinking and chronic pancreatitis. Do we have anything else?
Yeah, nothing else. Maybe we go for the exam.
Yeah, yeah, let's go to physical exam.
Okay. Yeah, so the general exam. So the patient was alert and oriented. He had
Mm.
severe generalized wasting. She was febrile. She was not pale, not jaundiced. She didn't have a rash and no lymphadenopathy and no rolling edema. Her vitals were within normal limit. And the systemic exam, starting with the upper abdomen, she had a scaphoid abdomen, epigastric tenderness, no palpable mass, no organomegaly. Neuro exam, eye centers and cranial nerves were normal. In the motor system, she had wasting in all muscle groups. She had a power of 4 plus over 5 in all muscle groups, but the tone, deep tendon reflex, and plantar reflex were normal. And she had normal sensory sensations. The respiratory system and cardiovascular system were normal.
Okay, so with this one, so basically what we see here is malnutrition, probably due to the nausea and vomiting. The patient cannot keep anything down. That's the closest explanation I see for the generalized wasting. And then what is making me think is the abdominal exam, because I mentioned some things like cyclical vomiting syndrome. Uh, I wouldn't expect any abnormalities in abdominal examination, especially the epigastric tenderness. Although, I mean, uh, clinically, these are the circles that keeps coming and going. The nausea and vomiting that comes, stays for a few weeks, and then disappears, comes back again, still makes me think of it. But for that one, I wouldn't expect to have epigastric tenderness. So I'm thinking the cause of this epigastric tenderness, of course, the closest ones that we know, peptic ulcer disease especially, can present with that, plus or minus gastritis. Maybe for whether so for something like chronic pancreatitis are not very likely to present with epigastric tenderness. So I'll still entertain those based on historical findings, maybe not because of this exam, but then the epigastric tenderness especially is making me think what is a local cause, especially especially in the stomach, that is causing this epigastric tenderness. So otherwise, the wasting that I see, I'm thinking is because of malnutrition. And the power, I wouldn't interpret it to be an abnormality, a neurological abnormality, but rather because the patient is weak. So I think we've discussed a number of cases here, and of course, whenever I approach weakness, that's the first thing I say, that you have to make sure that you differentiate a true neurological weakness from some other things that would be mimickers, like generalized prostration. Like in this patient, I'm thinking that is the thing. Things like stiffness. So for this patient, I think the power that you are presenting is because of weakness rather than a true neurological. I'm thinking it's because of prostration due to the malnutrition rather than true neurological weakness. So nothing very significant from the other systems. It's the epigastric tenderness that is giving me thoughts, is making me ask myself questions. What is exactly going on here? So probably this would point us in the direction of something local in the GIT, but then what is that? What is the exact thing that is going on? So that physical exam, I think nothing changed a lot. Let's see the labs in other investigations if we can make any progress.
That's a very good progress, by the way. So here are the labs. The FUBA picture showed mild anemia of 10.2, which was microcytic, normal platelets, her random blood glucose 5.2, which was normal, HbA1c 4.8 within normal limit, UPT was negative, MRDT, HIV, hepatitis B and C were all negative. The renal functions were normal. The liver enzymes were all normal. Amylase was 210, upper limit of normal 125, elevated. Urine analysis was normal. She had a moderate hyponatremia 123 and hypokalemia of 2.2. Chloride was 102, which was normal. Abdominal ultrasound was normal. So we kept the patient on IV fluids, KCl and IV ondansetron with IV metoclopramide, but she continued to vomit. We started her on erythromycin. Vomiting partially resolved and we discharged her, but she came back 2 weeks later. Vomiting started again, which made us think the erythromycin didn't help anything. We consulted gastro. Gastro saw the patient. He performed OGD, which was normal, and he suggested this patient needed expert review at a higher facility. So we referred this patient to a higher facility.
Okay, so starting with the labs, so the CBC, we see a hemoglobin of 10 point with a microcytosis with an MCV of 71. So we would think of iron deficiency anemia, but of course, I mean, with this nausea and vomiting, that would not be very surprising. Micronutrient deficiencies, that would explain it. So what is significant here, of course, this patient's diabetes is well controlled. So the patient is on oral hypoglycemics, metformin and glimepiride. The diabetes is well controlled. So you can see that the glycated hemoglobin 4.8, that is, so the diabetes is very well controlled. Uh, I do not think this brings any questions. I believe the patient is still on. The patient was on oral hypoglycemics. So what is significant here is the elevation in amylase. So 210, 125 times 2 is 125 times 2 is 250, right? So and half of 125 is should be 60 something, like 67 point, right? So the amylase is elevated, I think around should be around 1.5, the upper limit of normal. So to make a diagnosis of acute pancreatitis, for example, acute pancreatitis, you would need symptoms. The patient is presenting with symptoms which are suggestive of acute pancreatitis. So epigastric pain, of course, even vomiting would be part of those symptoms. But then when we talk about the elevation in the pancreatic enzymes, I think this is not very significant. Significant elevation. I'm asking myself, what is the correct number? Is that 3 times the upper limit of normal, I believe? So this is not very significant. And then the patient should have at least 2 of 3 actually. And the third one, so the first one is clinical presentation, so from history. The second one is these enzymes, so they are not significantly elevated. And then the third one is imaging abnormalities that are in keeping with acute pancreatitis. So I'm struggling to make a diagnosis of acute pancreatitis in this patient because I do not see her meeting the criteria for acute pancreatitis. But if we are talking of chronic pancreatitis, pancreatic enzymes are not helpful when you are talking about chronic pancreatitis. So symptoms and then imaging, those are the ones that can help you make a diagnosis of chronic pancreatitis, because with chronic pancreatitis, someone could have could have chronic pancreatitis, and then the pancreatic enzymes could be completely normal. So they are not helpful when you are talking about chronic pancreatitis. So the amylase, of course, is not helping me make a lot of progress here. The electrolytes, so sodium as well as potassium, yes, when someone vomits, especially a patient who is vomiting chronically like this one, we expect to see some electrolyte abnormalities. So I think these are because of the nausea and vomiting. And then the next one was it imaging? Abdominal pelvic ultrasound, which was normal. The next one. Okay, so patient is kept on fluids, and then erythromycin, which made the nausea and vomiting improve. Well, so erythromycin is a prokinetic. It's a prokinetic. So even when I believe people, especially students, when they read about upper GI bleeding, patients being prepared for emergency endoscopy, one of the treatments that are given is erythromycin as a prokinetic to make sure that gastric visibility is improved. So the fact that there was a slight improvement with erythromycin makes me think about one diagnosis that I mentioned of diabetic gastroparesis. Because so with the prokinetic, there is slight improvement, but then a question that comes is, if we are talking about a autonomic neuropathy involving the GIT, why would it be coming and going? I mean, if there is destruction to the nerves are destroyed. So that is what doesn't tally. But then slight improvement, of course, would be because of prokinetic effects of erythromycin. But then we see that it was not sustained. And then OGD is done and it's completely normal. So we had some distant differentials of peptic ulcer disease / gastritis. Of course, if with upper GI endoscopy, I believe, at least to a large extent, we believe that an ulcer would not be missed. Gastritis, they would report gastric erythema and edema, which are not reported in this patient. So I think we can comfortably throw them out that maybe we are not dealing with peptic ulcer disease or gastritis. So diabetic gastroparesis is still a thing that I'm thinking about. Cyclic vomiting syndrome, what doesn't help me explain it is the fact that this patient is also having epigastric pain. So by the way, cyclic vomiting syndrome is so you see that it can come in association with primary headaches, although sometimes it can occur completely on its own. So uh, yeah, it comes with the primary headaches, especially migraines. But otherwise, someone can have it on its own. So I'm not sure if we can term it part of the aura or not. So cyclic vomiting syndrome, diabetic gastroparesis. So chronic pancreatitis, acute pancreatitis, as I said, I have my reservations, and of course, 8-month history of nausea and vomiting. This wouldn't be termed acute pancreatitis anymore. Would be talking of chronic pancreatitis, and that one. So to make a diagnosis of chronic pancreatitis, would need imaging, CT abdomen. So that would show us an atrophied pancreas, probably with calcifications. So I think eventually, of course, I'll need to do CT abdomen in this patient for suspicion of chronic pancreatitis, although the absence of exocrine dysfunction of the pancreas, no steatorrhea, and things like those, normal absorption of any kind is making me a little bit reserved on chronic pancreatitis. So that's where I am. Anything else that you have for me, Joseph?
Yeah, yeah. So yeah, that's a very good place. Let's see what happened next. So we sent this patient to a higher facility, and when she came back, I looked at what they did there. So they performed some additional labs, which included CA125, AFP, and CA, which were all within normal limit. They also performed a contrasted CT abdomen pelvic, which was normal. She was discharged home with oral ondansetron. I read the disease summary from the hospital. It was written DM gastropathy as a disease diagnosis. But after 2 weeks from the discharge from that hospital, she presented again to my facility with the same complaint.
Okay, so doubts cleared. I said I would need imaging. So contrasted CT abdomen is not showing anything with with the pancreas, and they come with the same diagnosis. So I would say for treatment of diabetic gastroparesis or gastropathy, whichever term you use, we expect these medications, the antiemetics, the dopamine antagonists like ondansetron or metoclopramide to have some effect. So the fact that it's not responding, uh, that makes me think uh, right from the beginning against the diagnosis of diabetic gastroparesis. So there's a number of things that that are not explained in this patient. I'm thinking of committing to a diagnosis, but I think if I do, before processing those, I think to a large extent I might miss the diagnosis. So a 29 years old female diagnosed with diabetes for about 1 year, initially on insulin, which led to good glycemic control. But then 4 months down the line, she starts presenting with nausea and vomiting, which comes in cycles. So on further questioning, this patient doesn't seem to have to have symptoms that are pointing us in any other direction, because as I said, that nausea and vomiting can be due to local causes, which I think we've ruled out to a large extent. So maybe one more thing that we haven't talked about, but again, is not supported because this nausea and vomiting comes and goes in cycles, is what if we are dealing with an infectious cause of gastritis? This patient is diabetic, so could it be an infectious cause of gastritis? But again, if we are talking of gastritis and it's an infection, I'm not a gastroenterologist, and because I've not dealt with these things firsthand, maybe especially infectious causes, I think I would be a little misguided here. But then if we are talking about gastritis, wouldn't we expect some sort of inflammation that would be picked during endoscopy? So, and what sort of infection would come and go in cycles like this? So that is what is against infections, and of course we do not see the patient. We do not see other symptoms that are suggestive of an infection. So among local causes, I think infections are less likely. Peptic ulcer disease, gastritis, less likely because of the OGD that has been done, although we still have questions with the epigastric tenderness. Now, systemic causes. We've seen here that with systemic causes, a number of investigations has been done to be ruled out. Of course, neurological exam was normal. So thinking about features of increased intracranial pressure may be not very likely. What about other intraperitoneal causes? An abdominal pelvic ultrasound has been done, which is normal. Abdominal pelvic CT scan, or at least abdominal CT scan, has been done, which is normal. We had suspicion of chronic pancreatitis. CT is not showing any abnormalities. So what could be going on here? Of course, out of all the differentials that I've mentioned, I am not very confident in my final diagnosis, but I see one diagnosis remains standing, which is cyclic vomiting syndrome. But then, of course, I am not sure if it can completely explain, especially the epigastric pain, which would be suggestive of some local pathology. So that is the diagnosis that I see standing. I think to a large extent, I'm confident ruling out peptic ulcer disease, gastritis. The chronic pancreatitis that I was thinking about, imaging has been done, it's normal. So the sensitivity and specificity now, I mean, especially sensitivity, that would contrasted abdominal CT, miss chronic pancreatitis. Of course, that could be possible. I know that the sensitivity is well above 90%, but it doesn't mean it's 100%. But then if CT misses chronic pancreatitis, then what would diagnose it? That's a question that I have. So I'm thinking probably cyclic vomiting syndrome, although I should say I'm not very confident in my final diagnosis, because especially the new onset diabetes in this patient, what exactly explains it? So I'm thinking cyclic vomiting syndrome, still keeping diabetic gastroparesis low on the list, although I would expect some improvement with the antiemetics. So yeah, that's where I am, Joseph. I'm just waiting for you to teach me what transpired.
Yeah, so maybe diagnostic clue. We tried amitriptyline in this patient, and it caused immediate resolution of the symptoms than anything.
Joseph, you are muted.
Yeah, I'm very sorry. Yeah, here's a diagnostic clue. Probably, if you think of it that way, we tried amitriptyline in this patient, and it caused complete resolution of the symptoms than anything she's ever been on. Does it bring any ideas to you?
Yeah, so I mentioned cyclic vomiting syndrome. Cyclic vomiting syndrome, of course, as I said, it can exist on a spectrum with the primary headache syndromes, and we know tricyclic. I mean, yes, these antidepressants are some of the medications that are used as prophylaxis in patients with primary headache syndromes. I mean, with the confusion that I have for this case and the bias toward this knowledge of primary headaches, I'm thinking maybe that's why amitriptyline was helpful in relieving the symptoms. Whether amitriptyline has an effect, for example, on diabetic gastroparesis, I'm not sure. So I think that makes me lean more in the direction of cyclic vomiting syndrome.
Yeah, very good. You did the best, I think. This was a hard case to me and my colleagues, and you just mentioned CVS in the first the first slide of HPI, which is very nice. I like that. So uh, as you know, psychic vomiting syndrome, these are functional disorders. You don't have anything that you can do to see the diagnosis. So we are still on that. But this patient, ever since we have started amitriptyline, is like more than 2 months now. She's never vomited. That's why we think CVS must be the diagnosis here also. Maybe if she vomits again, we have to change and think of another thing now. But let's teach each other some stuff and learn from each other. So possible diagnosis, much of them you are stating them DM gastroparesis, but my colleagues questioned this in the hospital. Said it's too short. That the duration of diabetes just 4 months, and then you start having DM gastroparesis, but you never know. Maybe this DM was there, and the polyuria you're just seeing them after 1 year. Who knows? But again, the most common cause of DM gastroparesis is not of gastroparesis is not DM, it's idiopathic. So you can have DM and you can have idiopathic gastroparesis. Whether you choose to call it DM gastroparesis is up to you, but people with diabetes can have idiopathic gastroparesis. So the duration to me doesn't rule out the diagnosis of DM gastroparesis. But I've seen a couple of patients with of gastroparesis at all. I've seen no one admitted. These patients, you treat them outpatient. It's not that severe. The major problem, they will avoid to eat and they will lose weight. But the problem starts when they eat. They'll tell you food doesn't go down, which was not the case here. This patient, whether she ate or not, she vomited. And DM gastroparesis, you give them oral syrup on the syrup metoclopramide. They take it after each meal. They don't vomit, or they change their meal. They don't vomit. So that was less likely the DM gastroparesis. GO, very important. Someone who eats and vomit, you have to rule out the GO, gastric outlet obstruction, but OGD completely rules it out. Chronic pancreatitis or pancreatic CA, which was in the mind of the gastroenterologist, and that's why he wanted the patient to go on a higher facility. He thought because of DM at a younger age, this controlled by the pancreas, and but normal contrasted CT abdomen pelvic, it makes the diagnosis less likely, but it can't rule it out completely. The elevated amylase, yes, very good, David. It can take you away, but David tried so hard to say, okay, this is nothing, because even in chronic pancreatitis, it usually is normal because there are no cells there to produce amylase. But in subsequent visits, even in the visit at the higher facility, the amylase was normal. And severe vomiting causes elevated amylase. It is written in literature that I saw. So the amylase that was raised at my facility was because of severe vomiting. But to rule out chronic pancreatitis, you will need the MRCP or endoscopic ultrasound. Otherwise, you cannot say it's not there. But again, yes, the longer duration, 8 months of these are lethal diagnoses, pancreatitis, chronic pancreatitis, but there is no progress. You see, it's just there as a sake of vomiting. Not that patient goes into maybe exocrine pancreatic insufficiency, start diarrhea and stuff like that. Or you have pancreatic CA for 8 months and you just live in your life. Your only problem is nausea, vomiting, you can't eat. That would be hard to explain. But the most important thing, why should chronic pancreatitis resolve with amitriptyline? So the diagnosis out. One of my colleagues proposed abdominal epilepsy. He said he saw a case like this when he was young. So I had to consult a friend, a neurofellow, and she told me abdominal epilepsy can't present with isolated vomiting without a seizure. And she said she has seen a couple of cases in Mahenge of abdominal epilepsy. So this was not the picture that she expected. And she says because it's a seizure, there should be symptom-free duration before the seizure kicks in. Patient is normal maybe in a month, and then one day seizure comes up, they have a seizure, and they have intractable vomiting and nausea probably, which was not the case here. Earlier post-traumatic syndrome, which is a part of NMOSD, we also thought of it, but there were no other symptoms, CNS symptoms of NMOSD like hiccups, brainstem or spinal cord symptoms. And there is no good reason why it should respond to amitriptyline like this case is doing. And yes, finally, as you, David, is thinking, I had to go back and read and change because I diagnosed DM gastroparesis in the first place. But when I took this patient to the gastroenterologist and they came back with the diagnosis, the same diagnosis, and it seems there was no help, we had to go back and redraw and think what else could explain this. Plus, the comments that were made by colleagues that no, this can't be the, the case. So we didn't have nothing to lose. The psychic vomiting syndrome is a diagnosis of exclusion. As you can see in this patient, a lot have been excluded. And you try amitriptyline to see, even in patient with gastroparesis, if gastroparesis is not responding to the usual medication. I read in literature, they try amitriptyline. The thought is probably, yes, it's gastroparesis, but there is a component of CVS. So when we gave this patient a response, we gave this patient amitriptyline, it was the only time she has gone more than 2 months without vomiting in the last 8 months. And currently she's gained weight. She's thinking maybe she could go back to her job later. And some things are might be thought to be against CVS. I've seen one case of CVS in my life, but this was a 13-year-old girl, and I thought it's a diagnosis in kids. So I had to read, but it turns out, as we will see in the teaching points, adults also can have this diagnosis. So ages doesn't rule out. The migraine, so these are epidemiological stuff. Yes, higher percent of patients will have migraine in the patient or in the family members, especially in the maternal side, which was not the case in this patient. But the epidemiological stuff will not rule out a diagnosis when we do diagnostic reasoning. Maybe if you told 95%, it means 5% is possible, which can be the patient that you are seeing. Some teaching points. So, psychic vomiting syndrome, this is a idiopathic disorder which is characterized by recurrent bouts of vomiting, intervened by period of normal health, as we saw in this patient. But in this patient, it was so severe. The epidemic, pediatrics are more affected than adults. Mean age of diagnosis is 13 in pediatrics, 32 years in adults. That I learned this, that even in adults it can occur. Females more affected than males as in other functional disorders. So 72 to 82% will have a history of migraine in the patient or maternal family members, which leaves a room for more than 20% that will have no history of migraine. Maybe this patient is in that category. Pathogenesis is still unknown. Presentation, this patient will have recurrent vomiting, which can take hours to days with the absence of symptoms between episodes. There can be prodromes, things like nausea, epigastric pain. This patient had that. But again, this patient also, because of vomiting, maybe she was having erosive esophagitis. Of course, the OGD didn't see that, but I don't know, it's performed by a person. Headache can be there. 11% of patients can have an overlap between psychic vomiting syndrome and gastroparesis. That's why you have to try amitriptyline if you're seeing gastroparesis not responding to the usual medication. The way you make a diagnosis is clinical, as we are doing here, and you have to exclude the alternative diagnosis. Treatment will depend on severity. If it's just not like this one, just patient vomits 2-3 days, they go home, they continue their life. After 1 month, they do it again. You tell them to do lifestyle, take adequate fluid, avoid fasting, um, adequate sleep, and exercise. But once the vomiting have been established for some hours, like they've started vomiting in the past 4 hours, nothing can stop them, as we're seeing in this patient. no antiemetic would control the vomiting once they were established. But if you're seeing them, you just initially, like airy, you give IV fluids to repress what is being taken away. And on the cetron, they say it can reduce the numbers, but not so sure in the literature. But if you are seeing them airy, the vomiting is not established completely, like you're seeing them 1 hour or a few minutes. If you have intranasal IM sumatriptan, it will help to abort the subsequent vomiting. But if it is severe or very recurrent, like in this one, you try amitriptyline, which is a first-line medication, which we did in this patient, and luckily it responded. So this case told me a very important thing, but it's been repeated now that I'm being some years are going and I'm still being a general internist. You know, the super specialists are very good at what they are doing, and they are very helpful when you have them. They will do AGD, they will do this, they will do that, they will do cath. But what I'm realizing as I'm continuing to be a general internist is that they will never take away the role of a general internist, because like in this patient, you're taking a patient, you're taking the patient to them, you're telling them to go and rule out the causes of why this patient vomiting, and they come back, they tell you nothing, we're seeing nothing, we're seeing the pancreas is okay, everything is okay, and nothing is being done. So you can't pause and say this patient has a GI problem, has been seen by GI, and no, nothing is done, I stop here. General interest can sit and collect now stuff like this CVS is in the category not just GI, it's in neuro GI stuff. So who can do that? Maybe it's not neuro. No one can think of taking this patient to neuro. It's the general internist that can come up with a diagnosis, as David is doing here. So don't think of yourselves, don't think low of yourselves. We can do very good things, and we can direct this patient to the proper channel to see a proper super specialist, like go to neurology, go to GI. Yeah, maybe reflections from you, David. This was our case today. It was very long.
Thank you very much, Joseph. What I'm reminded of and what keeps me humbling when it comes to medicine is how a chief complaint, a symptom like nausea and vomiting, can be nerve-wracking. So I think that was very obvious today. Nausea and vomiting, taking me minutes, close to an hour, to figure out what exactly is going on. So I really appreciate this opportunity to learn. So I think it was a case very well prepared. And of course, just like you do many times, I mean, it's a job that you do very well, making diagnosis for patients that have been suffering for a long time. Because if you think about this patient, she has been walking around with the symptoms, changing hospitals over and over without much of help. But collecting the information, of course, history. Again, I think especially for our junior colleagues who are in this call today, they can see the importance of history, supplemented by a well done physical examination on how it can be very helpful. Because as you can see, labs were not helpful in making a diagnosis in this patient. Imaging, including advanced imaging like a contrasted CT scan, OGDs were done. No diagnosis was made. So it just took Joseph time to sit after collecting the information to think about what is going on in this patient. A diagnosis comes, the patient is treated with simple medications that are readily available. The patient is relieved of their suffering. So I think, of course, this is one of those cases that epitomizes the role of diagnostic reasoning, uh, which is very helpful, not just for the clinicians, but for our patients. So I think we fell in love with the right discipline when we thought that we need to improve our diagnostic reasoning on a daily basis. So thank you very much, Joseph, for the case. I think I learned a lot from it. Uh, Again, to remind myself that I should not ignore some signals, and I think it has been a good learning experience for everyone, including our junior colleagues. So thank you very much for the case. Now I see 6 minutes after the hour. So if there are questions or comments from anyone, just very quickly before we close.
I think there is nothing.
Yeah, I
Hello.
do not see any hands. Okay, welcome, Arnold, welcome.
Thank you. Hi, everyone. My name is Arnold. This is my first time joining this kind of sessions, and I find it quite interesting and deep discussions and challenges that we'll be able to pick up. So I really want to congratulate everyone for, especially for the presenter and the one who was contributing. I mean, trying to analyze every aspect of the case. This is a great work, and it shows advances in terms of our, care and everything concerning health. Initially, I had a quite number of questions, but I guess a lot of things have been said. Maybe because of I am not used to this way of presentation, because I thought maybe the presentation is going to be flowing from the beginning to the end. Then I jump in on questions, but yeah, it's okay. It's a great another way of approaching things. But anyway, regarding this is quite different case, eh? And during my practice years back, I like never had this kind of experience. I mean, the case. So one of the things that I came up or I was trying to think was, what if we make it as a case report, eh? Trying to highlight all those key issues and the challenges that were picked up during the whole course of treatment. I mean, the management of this patient, of this case, so that the young ones, the young doctors who are coming in, will be able to learn what are the possible challenges and how to navigate. I think this would be useful when, for example, if it happened that it is going to be published, and people will learn more than those who are probably happen to attend the meeting.
Thank you very much. That's a good comment. So I'm just thinking. So of course, very good. I believe so. For case reports, I think one thing that would make us struggle is, especially when it comes to international journals. Of course, if we find a way to document these kinds of cases and share them between us and in our local journals, I think that would be helpful. But when it comes to the international journals, especially including those that are publishing case reports, our challenge would be maybe they would say this is not something very new. Cyclic vomiting syndrome is something that is well documented from a long time ago. So I think that would be the thing. But then especially for local consumption, I think that would be very good just to make people aware that we have these kinds of things. I mean, we have these kinds of patients, because sometimes some cases not being frequently diagnosed in our settings make us think that maybe these things are rare or non-existent in our setting, but they do. Actually, sometimes it's just an issue of not being diagnosed. So I think especially maybe a way to go, of course, would be if we also happen to have our local journals which are publishing our case reports. I think that those ones would be very good for local consumption. So thank you very much for the comment. So I just wanted to take time. A number of people have already left, but so today we shared a link. We shared the link to the session, and we have found a way to make the call open to anyone. So you do not need to be admitted by the host of the meeting. You just click and you are in. So we shared it with a number of representatives for medical students to come in. So for those who are new, we do this mostly on Sundays at 8 p.m. And what we do is a case is presented in terms of value quotes, just like Joseph was doing. And then there is one discussant who is approaching a case to which they are completely blinded. They have not taken care of the patient. They do not know what the final diagnosis is. And then ultimately, what we need is to learn from the thought process of the discussant, how they approach a clinical problem. And of course, the goal, the main goal is not to get the diagnosis right. So if someone gets the diagnosis right, that's an icing on the cake. But what we are very much interested in is how they approach the case, so that we can learn from the thought process of a colleague. So we get to learn formulating many differentials from including from complaints that are not very familiar. So we basically cement what we read on the books, we apply them in real life cases. So that's how we do it. So it's open to everyone, whether you are first year medical student, second year, third year, anyone who is interested can join. So for those who are here, when you get the link, feel free to share to anyone, as long as they are medical students, they are residents, they are general practitioners, interns, specialists. Feel free to share to anyone. And for those who have cases to present, you are very much welcome. If you want to discuss a case, you are welcome. So yeah, that's how we do it. I see again Arnold with a hand raised. Please welcome. And this time, if you do not mind, maybe you can share with us where you are joining this call from and what you are engaged in, whether a practitioner or else. Please welcome.
Thank you. As I said from the beginning, I am quite interested by this. But my question was, for example, right now I am speaking. I'm in Europe right now. There is a course that I'm attending right now. So my issue is I don't know about this. Maybe if you have a platform or I don't know, social media or something that I'll be able to get the updates, because sometimes getting the links and depending on people could be difficult. I mean, some challenges could happen. So maybe if you have a systematic way of disseminating this information, like, hey, this time there'll be meeting, or maybe yeah, something like that. I don't know if you have that already,
Yeah. So
but
what we do? Yeah. So what
yeah.
we do is we share the link every Sunday, especially in the morning. We share the link. So maybe just to make sure that you get the link every time. How did you get hold of the link today? So that we make
Okay.
sure we maintain that contact.
I was able to get a link today on my. I have a group of my colleagues that we went the same medical school. Actually, on my background, I have a medical background, and I did my bachelor of medicine at
Mm.
KSMC, and I graduated on 2018. Right now, I'm in Europe. I'm doing my masters. So that's how I was able to get the link. But I am not sure if it's like what should I say? It's like I'll be able to get it at a time, or is it going to be like something that I can rely on maybe in this group, because I don't have any other platform to get this. That's what I'm asking.
Okay, so what we can do, if you do not mind, I'll share my email in the chat, and then you can contact me through that email, and then
Okay.
maybe I might need to get other contacts. For example, if you do have WhatsApp, I can add you to the link list, the list that
Okay.
I use every time to share the link. So
Okay.
After we do these sessions, we also post them on YouTube. So you can also go to YouTube and search AfroDX. So we have videos, I think, for more than a year now. I think
Oh,
more than 50 something videos. So you can also search AfroDX on YouTube and see the previous sessions. So after the sessions, we post the discussions there.
thank you so much. I am looking forward to that, and I'm looking forward to learn a lot from you guys. Huh?
Yeah, you're very much welcome. We're looking forward to learning from you too. So I've posted my email in the chat, so you can use that to contact me. Then we'll get
Okay.
contacts to make sure that we share the link every time.
Thank you so much.
Okay. Thank you very much, everyone, for joining today. So we are looking forward to having you back next week, and have a good night.